Sir, you are handsome, sir.
Sir, good evening, sir.
Thank
Vanakkam.
you. Vanakkam. Romba sandosam.
We are
Congratulations to
happy.
all of you, new office bearers. Congratulations to all of you.
Start பண்ணிரலாம் நினைக்கிறேன் இல்லையா
8 o'clock ஆரம்பிச்சு.
விஷ்ணு சார் அந்த கேமரா ஆன் ஆகல. So is it okay for you, sir? Vishnu sir, Professor Vishnu sir.
We have got at least 3 presenters, so I think we can start, sir.
Sir, Vishnu sir, okay? Is it okay? I am fine. Okay, sir.
Vishnu sir, no, on time, on dot. We have two moderators who are always on, want to things on the time. Both Dr. Binu and Dr. Vishnu.
Thabbi ஆரம்பிச்சிடலாம் தம்பி.
So we'll start on time. So okay. Good evening, everybody.
Yeah, sir. Okay, sir. Nice.
No, on time, on dot. We have two moderators who are always on to things on the time. Both Dr. Binu. Okay, good evening, everybody. It gives me great pleasure to have the 10th session of our 4C series, the crisp clinical case capsules. Today we are going to talk about emergencies in neonatal practice, basically at a primary care level. May I now call upon our sister, Dr. Dakshani, to say the pediatrician's prayer. Over to Dr. Dakshani.
குழந்தை மருத்துவனை நிறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது. எப்படிப்பட்ட சிறப்புரிமை என்பதை பணியுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர் தம் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தனவற்றை மாற்றோம், நல்லனவற்றை உள்வாங்கவும், மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளும். போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். தேங்க்யூ.
Thank you very much. The 4C series is the brainchild of actually our current president, Dr. Respiratory, sir, to have simple cases or multiple snippets of cases presented with the experts giving their opinion about management and their ideas about the diagnosis. So may I now request Professor Supracardiac sir to say a few words about the program.
Good evening, sir.
Good evening, sir. It's a pleasant occasion to join all of you, but seniors like Vishnu Bhai Ramaswamy sir and other senior people. And Binu Nayanan sir, I'm meeting after a long time. Yes. And congratulations to Rajendran sir for winning the election.
Thank you, sir.
And I'm respected, I'm honored by this opportunity. I am eager to listen to the presenters.
Thank you, sir. Over to Supracardiac sir. Supracardiac sir, please, sir.
Yeah, good evening, sir. Respected Secretary Dr. Tirumurugan, Treasurer Dr. Dakshayani, Editor Dr. Rajkumar, and the convener of this our Academy of Pediatric Sciences, Coordinator Dr. Rajendran sir, and he's become the President elect for 2023, and congratulations to him. And also Dr. Aswath, who is the convener for this 4C series. And the experts today, Professor Vishnu Bhatt sir, as well as Professor Binu Nayanan, and the various presenters who have joined today for an elaborate discussion on the common problems in neonatal practice, which is oriented towards mostly the practicing pediatricians. And I wish the program a grand success. This is the 10th program. I should wholeheartedly thank the organizers, the coordinators, the judges, the presenters, and everybody who have been supporting this program for the past 10 months. And it is one of our important activity, academic activity, as far as the IAP Tamil Nadu State Branch is concerned. So my wishes to all for a wonderful learning experience. And thank you. Thank you for this.
Thank you very much, sir. Now I call upon our academic coordinator, Dr. Rajendran sir, to say a few words and then start with the question.
Thank you, Dr. Thuru, and respected our dynamic president, Dr. Suresh Balan sir, and dynamic secretary, Dr. Tirumurugan, and President-elect Dr. Balashankar, and President past Dr. Ramesh Babu, and editor Rajkumar, and treasurer Dr. Dashani. And on behalf of IAP TNC, I welcome one and all. I welcome all the central as well as state DB members. And I really thankful to our 4C series team and coordinator Dr. Aswath, and as well as Dr. Sri Devi, Balaji, and as well as Dr. Palniraman and Raju sir. And on behalf of IAP TNC, really thankful to them. And I welcome today's experts, Dr. Professor Vishnupat sir from Pondicherry. He was retired director of pediatrics as well as neonatology from JIPMER. I welcome sir. I welcome Dr. Binu Nainan sir. He was supposed to be my college senior. And I welcome Dr. Binu Nainan sir. He's a well-known neonatologist. And once again, on behalf of IAP TNC, I welcome one and all. Now it's over to Dr. Vishnupat sir, please.
Good evening to everybody. I think it is nice that IAP is taking care of educating young people, and maybe it is meant for both postgraduates as well as practicing pediatricians and neonatologists. I am sure that the deliberations will be useful to all those who attend this.
Dr. Binu sir, please, some few words.
Thank you very much for giving this opportunity, and I enjoy these sessions, and I'm really looking forward to a very nice 1.5 hours, and I see there are a lot of presenters, so I'm really looking forward to that. Thank you.
Yeah, you can start presentation. I am on behalf of IAP TNC, I welcome my guru and teacher, Dr. M. Ramasamy sir. Just now he has returned from UK and as well as US also. I had a long trip. I welcome Dr. M. Ramasamy sir.
Thank you. Thank you very much. Thank you. I'm honored to see the Professor Vishnupat over there. So I'm very keen to listen to his observations and comments. And as well as Dr. Binu Nainan, because neonatologist, my neonatology knowledge almost goes back to 60 years ago while I was in New York City as a resident trainee. But now so much of new information, technology, as been generated. So let us listen to the presenters and also experts discussion, experts, the opinion of the experts. Yeah.
One small comment. I don't think Dr. Ramasamy remembers me, but I was his patient. Okay.
Dr. Uday, you can start your presentation. Uday? You can share your slide, please. Uday, can you hear me?
Yes, sir. I can hear you.
Yeah. Share your slide, please.
Good evening, one and all. I'm Dr. Uday Srinivas. I'm NNF fellowship.
Uday, we can't see your slide.
Yeah, you can.
You need to be louder also, Uday.
Okay.
Speak into the mic.
Share your slide. Share your slide, please. So otherwise, some other they can start presentation. Dr. Surbas.
Dr. Divya is here, Dr. Aruna is
Yeah.
here, Dr. Harini. Anybody who's ready with the presentation
Dr.
can
Divya,
upload.
you can start. Yeah, start your presentation.
Hello.
Dr. Divya, share your slide, please.
So 1 minute, sir. I'm sharing my screen. Sir, is it visible, sir?
Yeah.
It's visible.
I'm audible, sir.
Yes, you can proceed.
Good evening, all. I'm Dr. Divya, second year postgraduate from SRM Medical College. I thank IAP TNC's 4C series, my Dr. Subhash sir HOD, Dr. Prasna sir, and Dr. Ashok sir for giving me this opportunity. Today, I'm going to present a case of hyperleukocytosis in a young infant. So the presenting complaint says a well-growing female baby was brought at 20 days of life with the complaints of fever, cough, and cold for 1 day. The history of presenting complaints were a 19-year-old primary mother with uneventful pregnancy history, born at term by normal vaginal delivery with a birth weight of 2.3 kg. She was a SGA baby. Baby had a normal transition at birth. For SGA, baby was monitored, CBG protocol was done.
and CBG were within normal limits. Baby had neonatal hyperbilirubinemia, for which baby received phototherapy for 2 days. Baby was started on direct breastfeeding and KMC was given. Baby was discharged on day 4 of life with a weight loss percent of 8%. On day 20 of life, baby had presented to us with a cough for 1 day, not associated with any post-tissue vomiting, fever for 1 day, which is low-grade intermittent fever. Baby was continued on extensive DBS with adequate weight gain. No history of respiratory distress, lethargy, seizures, poor feeding. Mother had a history of cough for 3 weeks, and mother was on MDI, LABA, and corticosteroids. So the clinical features on day 1 of admission was baby's cry activity were good. On auscultation, baby had bilateral air entry was good with no added sounds. So the Downey score was 2 with mild respiratory distress. On day 5 of admission, baby had worsening of cough with cyanotic spells, tachypnea, lethargic, bronchospasmic episodes were present. Saturation at that time was 89% in room air. Other systems examination done was also normal. On day 7 of admission, baby presented with the acute life-threatening episodes with a severe bronchospasm following episodes of cough and apnea. Baby also had 2 episodes of seizures. So the investigations done on day 1 were HB done was 12 gram, total count done showed 18,760, platelets were 8,45,000, CRP was positive 64, the SGOTPT, RFT electrolytes were within normal limits, blood culture done was sterile. The CSF was actually done on day 5 of admission. So the blood count, repeat blood count done on day 5 showed HB of 12.5, total count was 97,170 and platelets were 9,50,100. On day 7, HB was 9.8, total count was 1,04,290, platelets were 3,74,000 and blood culture was repeated again. It showed blood culture to be sterile. CSF done on day 5 of admission was, CSF cell count was nil and the sugar was 42 and protein was 40. Chest X-ray done on day 1 showed increased bronchovesicular markings. This was the chest X-ray done on day 5 of admission, which showed right lung collapse. So the differential diagnosis now were infections that is to be late onset sepsis, viral pneumonia, neonatal pertussis. Since the blood culture was sterile, neonatal late onset sepsis was ruled out. Cardiovascular system, arrhythmia, congenital cardiac anomalies, tracheoesophageal fistula. ECG done was normal, so arrhythmia was also ruled out. Under respiration, aspiration pneumonia, chest X-ray didn't show features of aspiration pneumonia. Dyselectrolemia was also ruled out as electrolytes were within normal limits. And the other DD was leukemia. Since the elevated counts were, leukemia was also suspected. So second line investigations were done. Peripheral smear done showed moderate normocytic normochromic anemia with myeloid leukemia reaction, which was suggestive of a chronic infectious etiology. Bone marrow aspiration was done to rule out leukemia. It showed hypercellular marrow with erythroid suppression and shift to left with myeloid toxic changes. It was the chronic infectious etiology. ECG was normal. Echo done on day 5 of admission showed severe pulmonary hypertension with poor right heart functioning, and CAPSI was 4.4 mm. This was the picture of the bone marrow aspiration. And this is the echo showing CAPSI of 4 mm. So the diagnosis now is malignant pertussis. It was in view of severe PPHN and encephalopathy, and blood culture showed no growth. Bronchoalveolar lavage culture was done sterile. Bronchoalveolar lavage PCR viral panel was negative, but Botryella pertussis was found to be positive. It was bronchoalveolar lavage was done on day 7 of admission. So the treatment that was given for the baby was antibiotic coverages were initially IV amoxiclav was started, suspecting community acquired pneumonia. Later on day 5 of admission, as baby was worsening, antibiotics were escalated to meropenem, azithromycin to cover atypical organisms. Under respiratory system, baby was started on nasal CPAP, and later when the baby was worsening, baby was intubated and ventilated. and baby was nebulized with salbutamol, and IV aminophylline infusion was also started. For neurological conditions, for seizures, baby was started on IV phenobarbital, and IV fentanyl infusion was also started along with IV magnesium sulfate. For PPHN, baby was started on tablet sildenafil, milrinone, and inhaled nitric oxide was also given. High flow oxygen was also given. So this is the course of the baby in the hospital. On day 5, baby presented to us with a fever, cough for 1 day. On day 3, baby improved and shifted to ward. Day 5, baby was noticed to have cyanotic spells with acute life-threatening events. So baby was started on CPAP, and nebulizations and antibiotics were escalated. Day 7, bronchospasms worsened. Seizures were also present in baby. So baby was intubated. Bronchoalveolar lavage was done. Day 8, echo done showed severe PPH and severe bronchospasm. So aminophylline infusion, magnesium sulfate was also started. Baby was also started on dobutamine, milrinone. The report showed Bordetella pertussis positive. On day 9 of admission, baby had worsening of PPHN. So nitric oxide was started, and oral sildenafil vasopressin infusion was also started. On day 10 of admission, baby succumbed to the disease. So the discussion points: Bordetella pertussis is a highly contagious disease that presents with a paroxysmal cough and with inspiratory whooping cough, apnea, and cyanosis. Pertussis toxin actually inhibits the leukocyte functioning antigen 1 mediated arrest of lymphocyte production. CD62L expression is reduced. Hence, there is a hyperleukocytosis. This hyperleukocytosis causes vascular occlusion, and leukostasis results in pulmonary hypertension. So the general pertussis mortality rate is 1%, and severe it is 34.2%. Severe pertussis with PPHN mortality rate is 84%. For prevention, age-appropriate vaccines should be given to the babies, and Tdap is recommended in pregnancy. These are my references. Thank you.
Professor Vishnu Bhatt.
Yeah, I think initially, probably one of the diagnosis of pertussis would have been suspected because this child had a fever, cough, followed by ethnic attacks. But mother probably not given the TDAP vaccine, because now we advise maternal vaccination against pertussis, which probably was not given. And if it is suspected earlier, probably child might have done little better. But of course, our thinking may not have gone in this direction. And leukemia reaction is known to occur, so the high count, all these things are part of the pertussis infection. And as rightly said, in a newborn, it can be a very serious disease, and mortality also could be high. Probably starting azithromycin earlier and respiratory support might have done a little better, and could be some delay was there in starting the treatment. But once you don't think, probably you may not go in that direction. But whether it's pertussis or not pertussis, once a child was getting cough with apnea, I think we should have been very, very careful. This conversion could be because of encephalopathy, or it may be due to hypoxia during the apnea attacks. So I think there is a learning experience. One thing is that if the mother has not been vaccinated, a newborn has cough with apnea, one should seriously suspect pertussis. And with the leukemia reaction, I think they should have more likely thought of pertussis. But of course, the culture came that might have been a little late. Dr. Binu,
Thank you, sir.
add something?
Sir?
Dr. Binu?
Yeah.
Your comments.
Yeah, I think the diagnosis, if we had thought about it, I think we may have made a difference in the outcome. Because after the baby came, having been sent to the ward and then coming back with seizures, that is probably where the delay was. But having said that, it is very rarely that we see neonatal pertussis in real life. And the ones that I have seen usually responded very well. And very few actually went on to ventilation. So I think it's a question of recognizing and thinking about it when you get a child with cough and having a high white cell count, a leukemia reaction. That's probably where our thinking should have been. And I mean, always wiser once we have the diagnosis. But I would say that it is good that somebody thought about it even later and got a PCR done with which you diagnosed it.
Dr. Binu, can we have a couple of comments on what are the approaches to other causes for leukemia reaction other than pertussis and leukemia? What are the other conditions that we should consider if we have such high counts?
Usually the leukemia reaction is usually secondary to infections, and it is very rarely that we see it. If at all we see a leukemia reaction, we think about pertussis, and as you pointed out that it is secondary to viral infections. When we have unlike bacterial infections, mostly it is because of viral infections that we get a leukemia reaction.
Would you also see so much of a myeloid response? Because both in the differential count and the bone marrow, my concept was that lymphocytosis promoting factor, we get very high counts with lymphocytosis. She made it, but a very important observation that both the bone marrow and the smear, there was a shift to lead with a myeloid prominence. And such a high platelet count, is that also a feature of pertussis?
I think this is because of this pertussis in newborns, that is how they respond. Just like we say that there is no hoop. The myeloid response is in pertussis in newborns, it responds differently.
Dr. Ashwath, my take on this is a little bit different, even though, if I get a neonatal infant who has been well for some time and who begins to cough for no good reason, and he is afebrile, and the coughing persists, I only one diagnosis to make, that is pertussis until proven otherwise. It's as simple as that. And physical exam will rule out most of the other conditions mentioned in the differential diagnosis. These babies are practically afebrile, number one. Number two, the main presenting symptom is cough. Number three, the coughing comes on and persists. And physical exam excludes all the other conditions. One must have a high index of suspicion for pertussis and initiate. Nowadays, we have all this PCR culture. 10, 15, 20 years ago, we had none of these facilities. So simply on clinical grounds, we would start them on a macrolide antibiotic. And then the fact the mother had a cough again supports that contention, you see, and the diagnosis of pertussis. And so it's a relatively straightforward way of thinking. And another condition that you should worry, sometimes in rural community, they come to you after a few days of actually wellness in the baby, this oil aspiration. See, and this is actually not mentioned much in the Western books. So aspiration pneumonia also comes. So I think pertussis. And then, the presenter didn't give the differential count in terms of lymphocytes. See, we, usually 80 to 90% will be lymphocytes, often mistaken for leukemia. That's where the NCS make a big, mistake there. They mainly because they don't go and look at the smear themselves. They depend on someone else. You look at the smear, all the cells are normal lymphocytes. There is not even a single immature cell. And more importantly, reassuring to you that bone marrow is okay is normal platelet count. If you have a platelet count which is raised, there's hardly any bone marrow pathology. You need not even go and do the bone marrow examination. So with the hemoglobin near normal and your platelet also above, so hardly you're not going to have any bone marrow pathology. So I think it's a question of thinking about pertussis and then starting them early on macrolide. That will be my approach. And of course, PCR can get it done. Yeah.
Thank you, sir.
Ashwath, can I add only one point? Hello?
Please,
Ashwath?
please.
And usually when you have a high index of suspicion with leukocytosis and lymphocytosis, when you look at the smear, and special baby bottom lymphocytes are very characteristic of pertussis, which can be easily made out in the peripheral smear, along with the thrombocytosis, which is also well known in pertussis. Thank you.
Thank you. Dr. Divya?
Sir?
Okay, can you please tell us what the TAPVC of 4.4 is? I'm personally not aware of. What is TAPVC?
Sir, it is. Hello, sir.
But
yes. If you're using a terminology for the first time which is not familiar to mother, it's better to give the full form. You kept saying that the TAPVC was 4.4. What is TAPVC? Hello?
No, okay, Dr. Ashwath, if you permit me.
Unmute.
It is a tricuspid annular plane systolic excursion, sir.
What is the use of that?
Sir, it helps in assessing PAH, sir.
Okay, thank you.
No, Dr. Ashwath, actually, can I just add on to that? It basically looks at, it's one of the good ways of looking at right ventricular dysfunction. So normal would be about anything about 10, would be 9 to 10 would be more than that would be normal. Anything less than 9 is significant, and 4.4. Basically, what they are looking at is the kind of the tricuspid valve leaflet coming closer to the apex. So that movement is the one which is being measured. So 4.5 is pretty poor actually. It obviously suggests that there is significant right ventricular dysfunction. So is it primarily due to the hypertension, or is it a primary dysfunction? It's very difficult to say, but it does say there is significant right ventricular dysfunction.
Thank you.
Dr. Ashwath, with your permission, I would like to learn from the neonatologist about this associated pulmonary hypertension, which he mentioned, which seemed to have played a very significant role in this baby by the pulmonary hypertension. So I'd like to, know the, just to listen to them about their observations or comments.
Pneumonia or severe lung
pulmonary hypertension.
Pulmonary hypertension will develop because pumping the blood into the defective lung or infected lung become more difficult. So pulmonary hypertension will develop. So the more like respiratory distress syndrome, meconium aspiration syndrome, many of these conditions will cause pulmonary hypertension because there is pathology in the lungs. So once the pulmonary hypertension, the oxygen comes down. So you have to reduce the pulmonary pressure so that the blood flow will be better.
Does that answer your question, sir?
Yeah, thank you, because thank you very much. Thank you. Yeah.
Can I mention whether ECMO was thought about in this patient to the very end? Because some reversible conditions, ECMO.
Slides. I think the child was too sick for ECMO maybe because I think he had already apnea and respiratory problem. And ECMO facility may not be available in every place. So initial pulmonary hypertension management, of course, you reduce the systemic pressure and give vasodilator, which probably they have done.
Okay.
Dr. Uday, can you start presenting?
Uday, you can start your presentation.
Am I audible?
You are audible.
But your slide
not screen sharing.
Your slide not shared.
First, you have to open the slide, then you share. I think it's coming.
So is the slides visible, sir?
No, not yet. I can only see your screen. Yeah, now better. Yeah.
Yeah, you can go for a slide sharing mode.
Yes, sir. Yes, sir. Slide show, sir.
Start presenting, Uday.
Okay, sir. Okay. Yeah. Good evening, faculties and senior pediatricians and neonatologists. I'm Dr. Uday. I'm the NNF fellow at KMC. I'm happy to see my teacher, Dr.
Dr. Uday, can you just go on the slides?
Yeah.
Yes, yes, I'll start the slide, sir. Okay, sir. Thank you, sir.
Yeah, thank you.
I'm here presenting details of a 40 weeks old male baby who was born by normal vaginal delivery, birth weight of 3.3 kg. Upguards on birth was first minute 7 by 10.
Slide not moving, Uday. Slide not moving, Uday. Slide not moving.
You keep moving your slides.
Uday, not it.
Put on slides.
Not moving. Yeah.
Looks like we have lost his connection. So let him join. We will move on to the next speaker.
We'll go on to the case summary. Yeah, we will not waste time. We can have the next presenter. Dr. Harini or Dr. Aruna, whoever is there, can present.
Dr. Harini.
Dr. Harini?
Good evening, sir. I will
Yeah,
share.
can you please?
Is the screen visible, sir?
Yeah.
Yes.
Good evening, everyone. I'm Dr. Harini. I will thank everyone for this opportunity and Dr. Ramesh sir for this opportunity. I'm here to present a case of a One second, sir, sorry.
Yes.
21-year-old male baby who is a firstborn to a non-consanguineous marriage and an infant of a diabetic mother, born at a gestational age of 37 weeks by an emergency LSCS in view of fetal distress with a birth weight of 3.3 kg, came with complaints of fast breathing on and off for 3 days and yellowish discoloration of skin and eyes for 1 day. There was no history of feeding difficulty, lethargy, or decreased activity in the baby. No history suggestive of temperature instability noted. No history of suppressed suck cycle or bluish discoloration of extremities and lips. There was no history of reduced urine output. The antenatal, natal, and the immediate postnatal period of the baby was uneventful. The baby has passed the pulse ox screening at the time of discharge from the hospital. On examination, the baby was active, alert, euthermic, and was citric up to the abdomen. The head circumference, length, and the admission weight of the baby was appropriate for his age, according to the WHO growth charts. There was a weight gain of about 20 grams per day from the day of discharge. The vitals of the baby are heart rate was 150 per minute, respiratory rate was 75 per minute. There was no retraction, grunt, or cyanosis seen. The saturation was 85% to 92% in room air. There was no improvement in saturation, even with a FiO2 of 100%. The capillary refill time was less than 3 seconds. Peripheries were warm and the peripheral pulses were well felt. On systemic examination, bilateral normal vesicular breath sounds here. There was no added sounds. On serious examination, a short systolic murmur was heard in the pulmonary area. CNS examination was normal. Per abdomen examination was showed that the bowel sounds were here. Liver was palpable 2 centimeters below the right costal margin. Spleen was not palpable. Umbilicus was healthy. There was no obvious congenital anomaly seen in the baby. On further investigation, complete blood count was done, which showed HP of 17.6 grams per DL. PCV was 53%. Total count was 7,100. Platelets was 3,87,000. CRP done was 0.3, which was negative. Renal function test done, which showed a normal urea and creat value, and the serum electrolytes done was within normal limits. LFT done showed elevated serum bilirubin, ALP, and GGT. Blood gas done showed a pH of 7.31, PCO2 of 51, and HCO3 of 25.6, a picture of respiratory acidosis. Chest X-ray done showed a bilateral 8 lung spaces with the increased bronchovascular markings. The differential diagnosis were late onset neonatal sepsis, but there was no history of any temperature irregularity, and the baby was active. There was no lethargy seen, and the investigations were normal. There was the septic screen was negative. Congenital cyanotic heart diseases were considered. Inborn error of metabolism was considered as the baby was tachypnic at presentation, but the blood gas done showed respiratory acidosis. To confirm the diagnosis, echo was done, which showed that the pulmonary veins were draining into the SPC via vertical vein. There was a dilatation of the right atrium and right ventricle. Moderate trigeminal TI was seen, and moderate pulmonary arterial hypertension was seen. There was a 5 mm ostium secundum AST with a bidirectional stent, and the final diagnosis of unobstructed supracardiac total anomalous pulmonary venous connection was made. For initial stabilization, the baby was started on furosemide to reduce the pulmonary congestion. Phototherapy was started to treat the neonatal hyperbilirubinemia. Serum electrolytes were serially monitored till the surgery. A surgical repair of supracardiac TAPVC was done on day 4 of admission. The baby was extubated on day 3 of postoperative day 3, and was stopped off inotropic supports on day 4 of postoperative day. Currently, now the baby is on room air, hemodynamically stable.
Dr. Karni, can you take a break here, ma?
Yes, sir.
Dr. Vishnu Bhatt, sir? How do we differentiate as primary care pediatricians between respiratory causes for respiratory distress and cardiac causes for respiratory distress, sir? Are there any clinical pointers to make an early diagnosis of a critical congenital heart disease rather than giving antibiotics and oxygen?
Basically, when you examine the child, if it is a respiratory cause causing hypoxemia or the reduced oxygen saturation, obviously it should have significant respiratory distress. According to her presentation, the child did not have much respiratory distress, but the saturation was low. Obviously, this indicates that the child is having a heart disease. So, when the saturation is coming down, some cyanotic heart disease, then because when we discharge the baby, the saturation was fine, came back with the reduced saturation. Can the PG tell me why the saturation came down later, but not at birth?
Doctor.
Sir, it may be due to the patent ductus arteriosus closures.
Yeah, obviously the child's ductus arteriosus must be patent so that it helped maintaining the oxygen saturation. And this CRP was negative. That is obviously, and the child did not look sick and looked active. And you should not have put the sepsis as the first diagnosis. Probably as a postgraduate, you should have thought about heart disease. The first sepsis could have been put in the differential diagnosis. Similarly, inborn metabolism also, they may have transient problems. But the child basically presenting with the deoxygenation is not very common. So probably heart disease must have been thought about. So basically, if the respiratory system is the cause of hypoxemia, he should have clinically more respiratory distress in the form of increased respiratory rate or extra muscles functioning. Since this child was not having, I think cardiac condition must have been.
Thank you, sir. Dr. Binu?
Yeah, I'm not sure that the X-ray was normal because I thought the base of the heart looked quite large.
Go back to the X-ray. Go back to the X-ray if you can go back.
Yeah, look at that base of the heart. It's quite large, not the usual what you would say. And I would say that one of the common cyanotic heart disease that we often miss in a child is actually anomalous pulmonary venous drainage. So commonly the one that is infracardiac, but this happened to be a supracardiac one. And it's very common to see these borderline saturations, baby looking not very unwell, and you find that an echo shows pulmonary TAPVC. I agree with Professor Vishnu Bhatt that when the X-ray shows that the lungs are so neat and there's nothing much wrong with the lungs, it is unlikely to be a respiratory condition enough to produce hypoxia. To produce a saturation which is low, your lung should have been much more affected. And sepsis clearly is not the diagnosis. So it is a cardiac unless proved otherwise.
And Dr. Binu, can you please give us a brief about the routine practice that is recommended of preductal, postductal saturation that is recommended universally before discharge? What is its sensitivity? For example, in this child, we were falsely reassured by a finding of no significant difference between preductal and postductal. What is its pickup rate? What are the fallacies? What are the diseases that this preductal, postductal will actually miss? Can you please tell us?
Usually what we recommend is the critical cyanotic congenital heart disease screen done after 24 hours, and we do it at the right upper limb and the lower limb, and we expect the value should be anything above 93%, and the difference should not be more than 3%. It is supposed to pick up nearly 90% of the cases of cyanotic heart disease, but as you see, if the duct is open, sometimes we do make mistakes.
In this child, is that the probability? Because is TAPVC a ductus dependent lesion? We had a huge unrestricted ASD.
Correct.
So the baby's right upper limb also should have picked up the cyanosis, right?
Right, that's right.
So why was it missed in this baby? Is there a fallacy there?
There is a fallacy there, yes. Not all heart disease are going to be picked up anyway.
Okay. Dr. Anantaraman, the surgeon who operated, would you like to comment on correctable causes in the newborn presenting? Are you with us? Dr. Harini?
Yeah. Ashut, can I have one question for Dr. Binu? Hello.
Yeah, please. Yeah, please.
Dr. Binu, as a practicing pediatrician, till what day we have to see this right upper limb, right lower limb saturation? Because when the baby comes by 10th day or 14th day, but we usually think the PDA will close maximum by 10th day, and we usually see this practice of screening the cyanotic heart disease up to 10th day of life. Whether it is correct or we have to screen up to 14th day or whenever the baby comes in the neonatal period.
Usually we do it early because most of the idea is that when the duct closes, it will present. And the idea is to screen it before the duct closes, usually day 7 or day 10. If the duct is not closed, we can definitely screen it even later. But if a child has not presented till 7 or 10 days and the duct is not at close, then obviously that fallacy is always going to be there. But most of them close by 7 days.
Because we practicing pediatricians, usually we don't, because the neonatologists used to do the thing, and they come to us by 2nd week or 3rd week, whether we have to mandatorily do the screening. That is the thing, question I want.
I would definitely, if the cyanotic congenital heart disease has not been checked, definitely you need to auscultate the heart, feel for the femorals, and at least check the saturation in the upper and lower limb. And the saturation is above 94-95%, it is fine. But if there's a difference, you are have to come to the conclusion that the duct had not yet closed. In a cyanotic congenital heart disease, sometimes the duct closes later, unlike a normal newborn. So you may still find the difference.
Okay, thank you. Thank you very much.
Dr. Harini?
Yes, sir.
Is the cardiothoracic surgeon available here? Is he going to give his comments?
Sir, one small doubt, sir. Usually that PAPVC will be the acyanotic, but why this child has the cyanosis? Because of that large AST? Or they do the CT angio before that surgery?
No,
Dr. Binu, do you want to answer that?
Yeah.
No, Professor Bhatt?
Yeah.
No, it's a cyanotic condition only. At birth, because the PDA was large, probably did not have cyanosis. So after some time, it would have developed more cyanosis, maybe because saturation was coming down when he came again, because there is mixing of arterial veins blood. So obviously the saturation will come down.
Okay, thank you, sir.
Answer the question?
Dr. Kannan, is your question answered? Can we go on to the next case scenario?
No, the CT angio they performed before that surgery, because that PAPVC usually lately come with the pulmonary artery hypertension. But this only one supracardiac PAPVC come with cyanosis looks very unusual. That's what I'm thinking.
No, obviously when the saturation has come down, there should be a cause. As we discussed, either it's a respiratory problem or a cardiac problem. And this baby was just 20 days old or so. So it might have worsened if you have waited, and obviously it needs to be treated because the saturation was low.
Okay. Okay.
Thank you, sir. Thank you, sir. Dr. Uday? Dr. Uday?
It is not ready. We call Dr. Uday.
Yes, sir. I'll just try, sir, once more. Sir, am I visible? Am I audible, sir?
Yes, you are.
First, you open the slides.
Yes, sir.
You download the slides, then share. Then I think it may come. Yeah, I think now.
Give slideshow now. Perfect.
And sir, okay, thank you so much. Sorry for the delay. I'll directly go to the presentation. This is a 40 weeks old male baby who was born by normal vaginal delivery. Birth weight was 3.3 kg. Apgar was 7 by 10 and 9 by 10 at birth, which was normal. Baby had an uneventful day 1 course. Baby was having 2 episodes of vomiting, which was blood-stained, bilious, green colored, and blood in stools, 1 episode, and following which baby was referred to our center for further evaluation. So, history of presenting illness, baby had a day 1 uneventful course, passed urine and meconium on day 1. On day 2, baby on exclusive breast milk feeds developed 2 episodes of non-projectile bilious vomiting. It was non-blood stained. There was no history of any abdominal distension, no mass palpable per abdomen. Later, developed a blood in stool, which was small in quantity, which was associated with no refusal of feeds and no other bleeding manifestations. Baby on arrival was euthermic, pink in color. CRT was less than 3 seconds. Heart rate was 148, respiratory rate of 40. SpO2 was saturating normally in room air. All peripheral pulses were well felt. On abdomen examination, the abdomen was soft, which was non-tender. Baby was not wincing on abdominal palpation, and baby had no organomegaly. Bowel sounds were found sluggish, and other systems, cardiovascular system, S1, S2 was heard. There was no murmurs, no gallop, no abnormal rhythm. The respiratory system, there was no distress or any other neurological signs. So based on clinical evaluation, baby was evaluated for cause for intestinal obstruction, probably distal to the second part of the duodenum. And the differentials arrived were, first differential being malrotation of midgut with volvulus, duodenal or jejunal ileal atrasias. There could be a possibility of meconium ileus, NEC, which is a rare possibility, early vitamin K deficiency, bleeding, and Hirschsprung disease. So, based on the initial evaluation, baby was stabilized and baby was kept nil per oral, and investigations were done, showed hemoglobin of 14.3, total count of 9,000, and platelet was within normal limits. We checked on the coagulation profile, which was showing PT of 12, APTT of 31, and INR of 1. Baby had received vitamin K at birth. Electrolytes to rule out any hyponatremia associated with underlying sepsis or any NEC. Sodium was normal, potassium was on the lower side, calcium was normal, magnesium and phosphorus was a bit on the higher range, otherwise normal. Creat was within normal limits, 0.6. So for evaluating the diagnosis, we proceeded on to the X-ray. Initial chest X-ray with abdomen showed normal findings, but to rule out any cause of bowel obstruction, we proceeded with an upper GI contrast study. Here the upper image contrast study with an AP image showing a dilatation of stomach, and there is a dilatation of the first and second part of the duodenum. We can see an abrupt transition of the bowel contour. From a dilated stomach, there is an abrupt transition in the bowel wall thickness, and there is a spiraling of the jejunum, which is classically seen in malrotation. And then later in the follow-up study, we had seen a corkscrew appearance of the proximal jejunum. Ultrasound was done on the next day morning, showed altered SMA-SMV axis with clockwise direction, showing a whirlpool, classical whirlpool sign. There was a vascular knot, 1.5 turns, and the findings in the previous X-ray showing bowel and stomach dilated, and there was minimal ascites. So coming to the treatment, baby was taken up for emergency laparotomy by the pediatric surgeon, Dr. Nakumaran. On a table, there was a derotation of midgut volvulus done with LADS procedure and appendicectomy. Findings found were 360-degree volvulus of midgut and chronic congestion of mesentery. There was LAD span present with a narrow mesentery. The procedure done was the derotation with adhesive lysis, division of the Lanz band, and mesentery was widened up to the inferior border of pancreas. The replacement of the normal position of the bowel was done post the correction. So hereby showing the intra-op findings, there is the bowel showing the twisting of the jejunum, showing the malrotation, and then the bowel color was preserved, and it was normal with normal peristalsis was found. So just to show the contrast, if there will be any gangrene, so this will be the gangrenous bowel that will be visible when there is delay in the diagnosis and delay in referral to a pediatric surgeon. So this the picture didn't show typically of the malrotation, so I just put another image showing the typical spiraling of the jejunum here. So so etiology.
Thank you, Doctor. Thank you, Dr. Uday. We will stop here for a few minutes, and Dr. Vishnu Bhatt, sir.
This I missed which day it presented this?
Baby presented on day two of life, sir.
So initially it has taken feeds and passed meconium.
Yes, sir.
So obviously in a child who had no asphyxia and did not have vomiting at birth and no asphyxia, we should not really think of NEC and meconium amylase, that type of thoughts. So obviously it indicates that there is some acute intestinal obstruction probably, because initially it has passed meconium and there is not much blood, maybe a tinge of blood. That is what you said.
Yes.
So it looks more like an acute problem. So most common probably a malrotation of gut, as you rightly found. The other thing, of course, rarely intersection can occur, but I think malrotation will be more common in a baby 3-4 days old. And you are investigated and treated, I think, in the right direction. So if this baby has presented immediately after birth, during resuscitation, suppose upper intestinal obstruction, like duodenal atresia or upper intestinal obstruction was there, you would have had more gastric contents at birth. So this child has taken feeds past meconium, that indicates initially the bowel was patent and later this problem has been developed.
Thank you, sir. Dr. Binu?
Yeah, can you show me the initial presentation slide, please? Yeah. So I think the problem was that non-projectile bilious vomiting on day 2 of life. I think that was the initial presentation, isn't it?
Yes, sir.
And then later developed blood in stools, one episode.
Yes, sir.
Okay. So when the differential diagnosis here is, of course, on day 2 is malrotation. And as sir said, the chance of NEC, the chance of Hirschsprung disease is very unlikely. And I think you even put hemorrhagic disease of the, you are looking at vitamin K and all that, weren't you? As a cause of the bleeding?
Yes, sir.
Yeah. All those are, yeah, that's right. So these are all very unlikely differential diagnosis here. It is, as far as we are concerned as an emergency, the emergency is malrotation and volvulus. All the others are way behind. So it doesn't really matter. If a baby comes like that, the thing to remember and the thing that we need to aggressively interfere is the malrotation with a volvulus, because as you pointed out, if you delay it and you'll end up with a gangrene.
Yes. Dr. Binu?
Yeah.
Is there any medical cause for bilious vomiting that a pediatrician should know? Is it always surgical, or are there medical causes as well?
Yeah. In a baby on day 2 of life, like a term baby, I don't think medical cause comes as a priority at all. If at all, it is a diagnosis of exclusion. Very often in preterm babies, we would find that a small amount of bilious, light yellow colored bilious vomiting often comes as part of intolerance of feeds, where you do not find an intestinal obstruction. And sometimes sepsis is one of the reasons where you don't really have to think about surgical cause. But though sepsis may be as a medical cause one of the priorities, as far as the neonatologist or a pediatrician is concerned, if you get large bilious vomiting, the differential diagnosis, which is going to change the big outcome, is going to be malrotation.
Except on the first day, maybe if the mother had meconistein like he might have aspirated and it may come. But anything after first day, definitely it cannot be medical.
Ashwath, one question. Can I ask only one question? Hello, Ashwath.
Please.
Sir, for the practitioners, usually the standard staying bilious vomiting with normal abdomen in the first week is malrotation unless otherwise proved. Okay, here the question is whether now in this era, whether we have to go with the contrast barium, whether it is needed, because ultrasound itself picks whether it is needed as such an investigation.
Dr. Panina? I will ask Dr. Naga Kumran, who is a surgeon involved in this case, to tell us very briefly what is the approach to bilious vomiting and current practice guidelines. Dr. Naga Kumran, can you very briefly tell us what is the pediatrician's perspective, what we should not miss and how we should stabilize and shift, please?
Am I audible?
Yes, sir.
Yeah. So in this case, surgery was not at all difficult. The thing is, the referral pediatrician had diagnosed malrotation with the whirlpool sign, called us earlier than the baby arrived. And the neonatologist called me, and so I was in hospital about to leave, just stayed. This is very important. Otherwise, the patient would have ended up, then we would have gone and come back. All this time wasted would make a difference between the two slides I wanted Uday to show. One is our baby, one is taken from the internet, the complete gangrene. And to answer another pediatrician question whether contrast is needed, only when there is a doubt. I think the contrast is also mentioned as for completion, but it is not this baby's contrast. We went ahead with just ultrasound only. And very for the postgraduates' sake, a few points I want to add. The child, though vomited on the second day, the adhesions we found on theatre were chronic. So must have had in utero volvulus in the volvulus stage, in the mesentery. But when the volvulus gets complete, they present. So that is why they don't vomit on the first day. I will not be surprised if vomiting on the first day turns out to be malrotation either. One of our bosses, Dr. Bagdi, used to tell in ICH about his story where he taught MBBS students about malrotation. That night, one of the doctor's child presented with malrotation, they operated. We had one X-ray which showed a dilated stomach. Often this is a very good, important clue because you do see a lot of babies vomiting. Sometimes it is not presented to you in a busy day. I'm talking about PGs who are going to meet this in the future. Sometimes if you don't ask, they would have hidden the Baba suit with the green stain. So please take it into mind. You will be giving a child with 100 years normal life if you pick it up early. I think that's a good summary from my point of view. And small point is
post-operatively, are there some things we need to follow up these children for? After the repair, is there something we should follow up these children for post-op?
No,
because they'll keep coming back.
Some of them do need resection. Maybe, see, the volvulus is 360 degree, let us say, and the topmost part sometimes becomes gangrenous, other bit of bowel remains. Then in the long run, B12 deficiency and all comes in picture. But mostly nothing. The only thing which they present again and again sometimes is adhesive obstruction, which is part of any laparotomy.
Okay, thank you.
And the other thing, two more small points I want to comment. Most of these children with the chronic volvulus, they have, because of the increased lymphatic pressure, chylous ascites. This child had one. Number two, appendicectomy is controversial. It's on and off become controversial. Like sometimes they say don't do. Most people do anyway, because once we have done the LATS procedure, where will be the appendix? Where will be the pain referred to, etc. will be difficult. And every time they come with adhesive colic, you have to think of appendicitis. So for that reason, I nowadays do appendicectomy.
Thank you, Dr. Kumaran, for that inputs. Thanks, Dr. Uday. We will, for want of time, we will stop your presentation here. Can we have the next case, please? Thanks, Dr. Kumaran.
We will call Dr. Muthukumar.
Yes, please.
Dr.
Yes,
Muthukumar.
sir. Yeah, sir. I'll start sharing my screen. Sir, are the slides visible?
Yeah.
Perfect.
Yeah, sir. I'll go ahead. This is Dr. Muthukumar. I am a practicing pediatrician. I'm just here to present a case of respiratory distress in term. So, come to the case. This case was referred to us. I'll shortly go through the events leading to the referral. It's a 37-week, 3-day baby, and it was delivered in an outside hospital, tried immediately, and developed mild respiratory distress with a respiratory rate of 65 and minimal subcostal retractions. But eventually, the child didn't look that sick. So oxygen saturation was around 95% at room air, and the baby was breastfed once. So eventually, as time went on, respiratory distress worsened slowly, and when the hospital where the child was delivered, they took some time to pick it up. We received the child after 6 hours. So from that, and oxygen saturation had dropped to 90% then. So on arrival, the child's activity was a bit decreased, and perfusion was just about adequate. Central and peripheral pulses were well felt. Heart rate was around 150. Respiratory rate went up to 70. SPN saturation went down to 90%. And the cardiovascular system, no abnormalities were detected, and in the respiratory system, tachypnea was visible. Not very severe, but the subcostal retractions were present, and there were no added sounds. So per abdomen was soft, and CNS, the child's tone was normal. So the plan of treatment for this child, eventually, we did consider, do we consider high flow or CPAP or O2 through nasal prongs? So looking at the X-ray, the expansion was low, a hyperexpansion. We were able to see 6 intercostal spaces, and the diagnosis. So since it is a term infant, do we consider TTN or RDS? So looking at the X-ray picture and the eventual course of deterioration, we just considered term RDS, and we treated the infant as a term RDS. So treatment, we started the infant on IV fluids, and the routine investigations, whatever we do in the NICU, like the CBC, CRP, and the initial blood culture was done, and CPAP was started. So we put the child on CPAP, but respiratory distress, it took around 72 hours to settle. So then after 72 hours, we were able to de-escalate the support to high flow. And even then, the child required 12 hours more of high flow after weaning from CPAP. So feeds were initiated after weaning the infant. Sorry for spelling. Weaning the infant from respiratory support, and full feeds were reached over the next 24 hours. We slowly escalated the feed. So risk factors for term RDS, term RDS tends to be missed quite often. So the risk factors are what we should keep in mind are GDM, oligohydramnios, low birth weight at SGA infants, and obviously meconium stained amniotic fluid, birth asphyxia, and maternofetal infections. Male children, okay, the male infants, and selective LSDs.
Thank you, Dr. Muthukumar.
Yes, sir.
Can we take a brief pause? Can you go back to the X-ray, please?
Yes, sir. Yeah.
Professor Vishnu, but can you please teach us the basics of neonatal chest X-ray interpretation, sir?
Actually, it is better to have a good inspiratory film. But if you look at this film, it looks more of a expiratory or mid-inspiratory film. So it is very difficult to make a comment on the bronchoscular markings. It appears as if it is increased. It may not be really increased. Mild hyperinflation appears to be there. So any respiratory distress, mild hyperinflation be there. But otherwise, cardiac size, then diaphragm, everything looks quite normal. So basically,
pardon my interruption, sir.
No?
When the baby is having, pardon my interruption, when the baby's respiratory rate is 70, how do you actually get the technician to shoot a good X-ray, sir? It will be very difficult to get inspiratory film.
That is depends upon the expertise of the technician. So
Sure,
yes,
sir.
And then click, but it may happen, it may not happen. So it is a difficult. I agree with your point. But looking at this X-ray, it looks more like a TTN with because mild increased bronchoscular marking, mild hyperinflation is there. So otherwise, basically the X-ray looks quite normal. So in the child, which is just a baby, 37 weeks old, as he rightly put, it can develop RDS also, but usually they will be milder. The more mature they are, the respiratory distress is milder. And one should differentiate between the respiratory distress and respiratory distress syndrome. Respiratory distress is a broader terminology which includes all respiratory distress or difficulty in breathing. Whereas respiratory distress syndrome, when you say you mean hyaline membrane disease, which is a more definitive diagnosis. So when you say meconium aspiration, all these will not come in the cause of RDS. They will come in the cause of respiratory distress.
Dr. Muthukumar, you wanted to add something?
Yes, sir. Like the X-ray was taken when the infant was put on CPAP. Like we usually take the X-ray only after putting the infant on CPAP and leaving it on for 2 hours. So even with that, since the expansion is poor, like we were more inclined to go with the diagnosis of term RDS.
Dr. Binu?
Yeah, first of all, I think the X-ray, the hand position is not right. It should be above the head, and positioning is not right. One thing. Second is I may not agree with Dr. Muthukumar that I would wait for 2 hours before an X-ray, because I often have children with pneumothorax presenting, and therefore waiting for 2 hours is already have a supposition that the child has got an underlying disease. So because we don't have the diagnosis, it could be a diaphragmatic hernia, it could be a cystic adenoma malformations. You can have other reasons for respiratory distress. So definitely, I think an X-ray should be done immediately. And second, of course, I don't see a blood gas, because to me, a baby with respiratory distress, an X-ray and a blood gas comes hand in hand. I don't know if you didn't have the facility for doing it, but that really helped. Otherwise, pretty much the important thing in neonatology is that if you have an X-ray and a blood gas, whatever be the etiology of the respiratory distress, the management is the same. If you have a child who has got oxygen requirement and has got respiratory distress, you just put the baby on CPAP. So whether it is TTN or RDS is purely a theoretical discussion. And as the child is more term, you probably like to call it as more TTN. And if you don't, if it is more preterm, you tend to call it as RDS more often, unless the X-ray is very classical, you have a lot of whiteout lungs or otherwise. Otherwise, the point of management from the point of a pediatrician is very simple. A child with respiratory distress, needing oxygen, has got distress, you put on CPAP, you put a Silverman or a Downey score, and come to a conclusion, get an X-ray, get a blood gas, and go ahead.
And Dr. Binu, he made a comment about the child being weaned off from CPAP to high-flow nasal cannula. For the generalist, what would you suggest as the primary mode of respiratory support when we don't know the etiology, or the etiology is not a clear-cut whiteout lung? Is there a choice to be made between CPAP and high-flow nasal cannula, or can we switch starting from HFNC to CPAP and vice versa? which is the go-to modality of respiratory support?
The go-to modality, as far as I am concerned, in my practice has always been CPAP. For a number of reasons. One is that if it is a lung which is tending to collapse, like an respiratory distress syndrome, surfactant deficiency or otherwise, you need more positive pressure. The second reason is that the high flow, humidified high flow nasal cannula that they talk about, what we usually or often have in hospitals is just connecting a humidifier and connecting to a flow meter and then pushing up the flow to, say, more than 2 liters per kilogram or whatever we do. This is not the same as a real proper HFNC that is used for, say, bronchiolitis. So overall, as a standard practice, any child with respiratory distress needing respiratory support, I would say CPAP would be the first modality. I'm sure there are a lot of other people who would argue other way around, but I would say the rule of thumb is put on CPAP, that would be the safest to do.
Thank you. And would this baby have benefited from surfactant? Would we wait for CPAP to help the baby, or should we go upfront and give surfactant regardless of the fact that it's a term baby? At what point would this baby get surfactant?
The primary modality of treatment is to support the breathing with positive airway pressure. CPAP is more important than surfactant. Surfactant is just going to buy time, but CPAP is the more important thing. If the oxygen requirement has gone up, say, for more than, say, 40% or so, or the blood gas has shown a deterioration, then probably yes. But otherwise, for the minimum amount of distress the baby had, I would definitely not think it warrants to be given surfactant. No.
Okay, thank you. Dr. Muthukumaran, are there any concluding remarks that you would make before we close and go on to the next case?
Yes, sir. Regarding the X-ray, we'll go ahead with an X-ray if the infant is very sick. If the saturation is maintained very well and FiO2 requirement is quite low, so we allow the infant to settle maybe for an hour or two before we go ahead with an X-ray. And if the infant arrives very sick, we go ahead with an X-ray immediately. And surfactant, again, if FiO2 requirement is creeping up and respiratory distress is worsens despite adequate CPAP support, it's better to go with surfactant then. So most of the cases, they don't require surfactant. So then, to the point, I'll go ahead. I'll finish off, sir. And take-home points like respiratory distress in term babies can be easily missed. They are the ones who are frequently missed, and there are delayed referrals. And the infant may look deceptively comfortable on HFNC when finally they'll land up with CPAP again. So whenever I give CPAP support, we should give adequate time on CPAP before we go step down to HFNC. And chest X-ray helps in deciding the line of management. And delayed referrals and delayed initiation of CPAP will prolong hospital stay. Those infants, they tend to drag on. Thank you.
Thank you, Dr. Muthukumaran.
Thank you, sir. Yeah.
Tirubro, somebody else is there? Dr. Aruna? Is a group from Dr. Balaji, students from Dharmapuri? Is anyone available, ma?
I think Dr. Niranjana Devi is there, so we'll. I think we can ask her.
Okay.
Is Dr. Aruna is there? I'm just trying to figure out.
Dr. Niranjana?
Yes, sir.
Yes, ma. You can start screen sharing. Start your presentation.
Excuse me, sir. This is Aruna. I've been trying to.
Who is presenting now? Dr. Aruna or Dr. Niranjana?
Dr. Aruna is presenting.
Sir, is my screen visible, sir?
Yes, ma'am.
Yes.
Please.
Sir, good evening to everyone. I'm Dr. Aruna, final year postgraduate from Coimbatore Medical College. This is about a newborn. I'm beyond neonatal age, but still a term baby of birth with 3.2 kg, normal neonatal transition presented. With neonatal jaundice, we treated the child with phototherapy for 4 days, and then we discharged the child, gone to a G2 PM mother with uneven full antidote. After 25 days of life, the same was presented with low weight gain and staining of diapers with aesthetics. Moving on to a detailed history, uneven full antenatal and birth history. Child got treated with phototherapy for 48 hours 40 hours from day 4 of life. At day 25, same child presented with failure to thrive, persistent jaundice, and ankle. Clinical features: child had increased up to palms and soles, formed abdominality, no pallor, no bleeding manifestations, failure to thrive, and no extravasation. This is the same picture of the child taken after 1 month of the second admission. The child progressed to have ascites, signs of other hepatic failure and coagulation. Moving on to the investigations, liver function tests showed high total bilirubin with the predominant direct component of 8.5, with elevated liver enzymes in the range of 300. Alkaline phosphatase was elevated. At day 25, total protein was 6.7 and albumin of 3.5. In order to rule out hemolysis, we took a clinical smear which showed no evidence of hemolysis and HP of 10 and KD of 4.8 marks. USG abdomen showed heterogeneity with gallbladder being visualized, and since there is a direct hyperbilirubinemia, we proceeded with GGT levels which were normal. Thyroid function tests were normal and loss was negative. In this clinical spectrum of persistent decrease of the palms and soles with hyperbilirubinemia, any platelet stools, failure to thrive, and predominant direct hyperbilirubinemia without any evidence of hemolysis, elevated liver enzymes ALP, with normal GGT and the child showing signs of liver failure. We first ruled out common causes like neonatal hepatitis secondary to inflammatory infections and sepsis. Cultures were medical, thoughts was also ruled. Other immune components like gestational alloimmune disease is also thought of. Serum clinical was normal. Metabolic was also ruled out. GHD was ruled out with a gallbladder being placed in USG. In this clinical spectrum, with the normal GGT, we thought of other disorders like T-FIT, progressive delayed cholestasis. We moved on with the genetic analysis at 3rd month of life, same child. Turned out to be a case of bile acid synthesis defect type 1. So it is an autosomal recessive disorder. Enzyme deficiency involved in bile acid synthesis, like folic acid and phenodiazepoic acid, not synthesized in this defect. The enzyme deficient in this case is 3-beta hydroxysteroid dehydrogenase, which is involved in the second step of bile acid synthesis. So what happens is that normal bile acids are not synthesized, hence they are not. This leads to production of abnormal intermediates that tend to accumulate in hepatocytes, resulting in hepatic cholestasis. So obviously, secondary to cholestasis, the child shows features of failure to thrive with progressive hepatic failure and fat soluble vitamin deficiency. Follow-up of the child at presentation in newborn period with an icterus treated with phototherapy. At 25 days of life with persistent icterus with failure to thrive and more of a direct component. 3rd month of life, the same child showed signs of liver failure with persistent cholestasis and failure to thrive with ascites coagulopathy. The preliminary treatment in this child is, since there's deficiency of primary bile acids, we started the child on primary bile acid supplementation in the form of folic acid, and the child is also started on fat soluble vitamin supplementation. Child succumbed secondary to liver failure. So, take home message. Any jaundice persistent beyond 14 days is pathological. Always look for stool color and urine color during examination. Failure to thrive with jaundice warrants extensive workup. Treatable causes of jaundice should be prioritized, like sepsis or inflammatory infections or other treatable causes like tyrosine or this. After that only, we have to look for rare cases, as in this case, it turned out to be a case of congenital hernia. Compulsory follow for any jaundice treatment.
Thank you, Ma. Thank you for that elegant presentation. Professor Vishnu Bhatt.
It is an interesting case, but only my comments. This baby had jaundice even at discharge. So I don't know why it was not followed up. Either the parents did not come or it was not advised properly, because it came back after 25 days or 30 days with failure to thrive, abdominal distension, and in a very bad shape. Not that you would have done very great if you continued to keep the baby in the hospital, but probably the diagnosis might have been done. I have not seen this case earlier, but probably only liver transplant may be the only answer, because if it is not able to produce liver enzymes, then that may be the only, maybe the mode of the treatment possible. Whereas
Sir, can you?
in the family, any history there?
No, sir.
No, sir. The elder sibling was normal.
So this could have been a genetic mutation study could have been done. At least parents, whether they are normal or abnormal, we could have checked. And baby's mutation analysis could have been done. Because this is a second baby, isn't it?
Yes, sir.
Yes, sir.
So if they want to have one more baby, probably that could help.
Sir, what are the absolutely non-missable conditions that every general pediatrician should pick up, sir? In direct hyperbilirubinemia, what is the basic minimum workup that we need to do?
The direct hyperbilirubinemia is always abnormal. So unless it is a congenital direct hyperbilirubinemia, which transiently maybe there are mild hyperbilirubinemia may be there. Otherwise, always it indicates there is some obstruction to the bile flow. So it is always pathological. So once direct hyperbilirubinemia is there, we should look for a cause and try to identify and treat. Rarely congenital direct hyperbilirubinemia can occur, but usually it will be much milder than other pathological causes. So any child jaundice should disappear, and if it has come down, you should do follow-up till it becomes all right, whether it's direct or indirect. But indirect is much safer compared to the direct. Direct is always pathological. So I think we should be very careful with the picture she showed initially looked like kernicterus, maybe the picture of another baby. So the first picture she was showing.
Arching was.
This one. Is it look kernicterus?
Was it the same baby?
No, I think it's
Huh?
same baby.
Yes, sir.
But abdomen
baby is
normal
definitely arching.
Or it has already developed kernicterus after that abdomen discharge. Dr. Binu, you may want to add something more.
Yeah, I think one thing that usually these are rare conditions, but the common things that we talk about is a baby coming with persistent jaundice, especially a direct hyperbilirubinemia. You have to rule out a urinary tract infection. I've been caught out before with one of the authors, one of my teachers who was actually an author of hepatology. The child comes with classical extrahepatic biliary atresia, but you sent up a urine culture, it came as E. coli. And you treated that, the whole thing disappeared. So cholestasis is known as a urinary tract infection. So UTI, hypothyroidism are the two medical things that you have to look at. And as a pediatrician, we have to rule out extrahepatic biliary atresia and then look at neonatal hepatitis as an etiology. And then now that we have genetics, if none of it is there, then of course, we have to look at the genetic reason of why it happens. But I would say the urine culture would have been, from my pediatric point of view, I would have said urine culture and thyroid should be part and parcel of any child who comes with a jaundice.
Dr. Binu, before we close this case discussion, can you please enlighten us on the current diagnostic workup of direct hyperbilirubinemia? What is the role of EDA scan and is the role of biopsy? Do we need to continue to perform the EDA scan or should we go ahead with the liver biopsy, which is the best sensitivity to pick up biliary atresia?
Yeah, we still go ahead with EDA scan and then followed by biopsy. So there's no change in that. So as I said, the child comes with the direct hyperbilirubinemia. You do a urine culture, you do a thyroid scan, the thyroid test, we do an ultrasound abdomen, and we do the liver function test. You look at the coagulation profile. These are the basic things that we do. And after that, we come to the conclusion that this is going to be a differential diagnosis of a liver pathology. And then we have to do a EDA scan, and then we look for a liver biopsy. That's exactly the same order that we do, that we don't change it.
If the EDA scan shows a trace of the tracer excretion to the gut, should we still go ahead with the biopsy or is that step bypassable?
It is not bypassable. Without a liver biopsy, we will not be able to come to a conclusion eventually.
Okay. Thank you.
Sir,
is there any
Sir, shall I add?
Sendil?
I'm Dr. Sendil.
Dr.
Yes, sir.
Sendil, please.
Yes,
please.
yes, sir. This is Sendil from neonatologist from Coimbatore, sir. Sir, this particular case has been presented here because usually when we treat, we thought that there is no incompatibility. We thought it was an indirect jaundice. Regular counseling has been done for follow-up, and this child landed up with the primary care pediatrician elsewhere. But this enters into the pediatrician's mind, the follow-up pediatricians. Treatment for jaundice has been received. Anala mild irukum. There will be some mild jaundice. Anala onnu illa. But that question like high colored urine, intermittent acolic stools, on the particular history, if it has been asked, simple history, it has been asked, that baby wouldn't have landed up to us again with failure to thrive, sir. That's the reason one we have presented. So jaundice, many a times, sir, we think it is very easy, simple. We discharge even without seeing. Even with our experience, we see full of blanch everything is fine, no incompatibility, nothing. Started taking feeds, stool color has changed. We send, but definitely we need to follow up each and every case of jaundice. That should be a lesson from this baby, sir.
Correct.
Number one, logistic reasons we couldn't do liver biopsy, all those options we couldn't do. We got the report post after the death of the baby only, sir. Thanks, sir. Thanks for the present. Thanks for
allowing. You should have done follow-up because direct hyperbilirubinemia is there.
No, sir. Later on, initial didn't have, sir. This baby didn't have. But 48 hours it received phototherapy, didn't have. Later on, that's what, sir. It was not being worked up. It came with liver disease.
Child went home after treatment for indirect hyperbilirubinemia, came back unwell in the end of the neonatal period with the direct jaundice.
Yes,
there is a break between.
Yes, sir. Yes, sir. Yes, sir.
Thank you, Dr. Sandil, for that comment.
Thank you, sir.
Can we go on to the next presentation, please? Dr. Niranjana Devi, are you ready to share, ma?
Yes, sir.
Yes, ma. Please start sharing.
Dr. Aswar? Dr. Aswar?
Yes, sir. Yes, sir.
Now, may I make one request through you to the presenters? Would please request them to give their clinical diagnosis before showing the investigations.
Sure, sir.
See, they show the entire, from the A to Z. We really do not know what went through their minds before they ask for the investigations. So could you please request them to tell us what went through their mind before they started asking the investigation? Yeah, please.
Sure, sir. Right. Thank you, sir.
Am I audible, sir?
Yes, ma'am. Please present.
Good evening to all the respected faculties in the panel. I am Dr. Niranjana from Madurai Medical College. I am here to present a case report of a bleeding neonate. This is baby of Divita, female baby, born of third-degree consanguineous marriage at gestational age of 39 plus 5 days through elective LSCS in view of IUGR. Baby cried at birth. Birth weight was 2.1 kgs and baby was referred at 12 hours of life in view of respiratory distress and ecchymotic patches noted over the trunk. Relevant pregnancy history. Born to a 22-year-old primary mother. Anomaly scan done at 23 weeks of gestational age found to be normal. History of gestational hypertension noticed at 7 months of amenorrhea and started on antihypertensives. Pregnancy weight gain was 7 kgs. USG done at 39 weeks plus 3 days showed fetal growth restriction with high resistance flow in umbilical artery, proceeded with elective LSCS. Admitted at GRH Madurai at 14 hours of life, baby was kept on O2 basic investigations were sent. In view of low platelet count, platelet transfusions were given. Baby was weaned to room air on day 2 and no further bleeds noticed and started on feeds. Coming to the clinical features, baby in room air on examination, no pallor, no icterus, no cyanosis, ecchymotic patches noted over the trunk, vital stable, anthropometry, weight and head circumference falls below third centile and length at third centile. Ponderal index is 2.1, which fits into symmetrical IUGR. On head-to-foot examination, dysmorphic face is noticed with flat occiput, wide open AF and PF, upward palpebral slant, low set ears, short stubby fingers, bilateral clinodactyly, pandal gap, and loose holes of skin noted. On systemic examination, respiratory system, bilateral air entry present, chest wall symmetrical, with downs of 2/10, abdomen soft, no distension, no hepatosplenomegaly. So regarding differential diagnosis, this is a baby with a Downs phenotype with IUGR. Placental insufficiency or IUGR ruled out in view of persistent thrombocytopenia. Blood counts initially done, platelets shown 17,000, for which platelets were transfused. Total count was elevated, 46,900. In view of thrombocytopenia, maternal platelets were viewed, they were found to be normal. On serial complete blood counts, platelets were found to be persistently low, and the total leukocytes counts were increased. Coming to the peripheral smear, initial peripheral smear study showed many nucleated RBCs and severe thrombocytopenia. CRP was found to be elevated, hence baseline antibiotics were started. Coagulation profile was found to be normal. And coming to the liver enzymes, bilirubin was elevated on day 4 of life, for which baby was received phototherapy for 3 days. Liver enzymes were normal. Coagulation profile was found to be normal. And blood culture indicative of Pseudomonas growth. The antibiotics changed to culture sensitivity antibiotics. Thyroid profile was found to be normal. Torch profile negative. And X-ray both forearm and chest normal. Ultrasound abdomen and pelvis, no evidence of ascites or hepatomegaly. Ultrasound gradient, no evidence of hemorrhage. Echo study normal. Karyotyping confirmed the diagnosis of Down's genotype with 47X plus 21. Coming to the differential diagnosis, Down syndrome with early onset thrombocytopenia, placental insufficiency or IUGR as a cause of early onset thrombocytopenia ruled out due to persistent thrombocytopenia. Sepsis or DIC ruled out because after starting culture sensitivity antibiotics, platelets has not improved, and also coagulation profile was normal. In view of neonatal alloimmune thrombocytopenia, 1 dose of IVIG was given, but platelets has not improved. Torch panel turns to be negative. We left with trisomies like 13, 18, and 21 with Down syndrome with a Down's karyotyping of Down's genotyping. Down syndrome with Cori abnormal myelopoiesis. We thought of Cori abnormal myelopoiesis. So we proceeded with bone marrow study, which showed 12% blast and future suggestive of transient abnormal myelopoiesis. And flow cytometry was sent, which showed 3.9% myeloid blast expressing platelet surface antigens of CD7, CD117, CD61. Again, substantiating the possibility of transient abnormal myelopoiesis. So we concluded with a final diagnosis of Down syndrome with transient abnormal myelopoiesis. Regarding treatment, supportive treatments were continued to the baby, and baby was kept on observation. On follow-up, failure was present, minimal weight gain was present, and regarding complete blood counts, total counts was come down. Platelets still remain in lower range. On discussion with the oncologist, they have kept the baby with supportive transfusion care and as well as weekly CBC monitoring.
Thank you. Thank you, Doctor. Can we take a pause now? Professor Vishnu Bhatt, yes. How do we approach children with thrombocytopenias and newborns with thrombocytopenia? Can you give us some guidelines?
Actually, this child had features of Down syndrome as she presented. If it is only intrauterine growth restriction with ecchymosis, thrombocytopenia, one should think of intrauterine infection. So possibly the first diagnosis would have been intrauterine infection, but for the features of Down syndrome. As we know, that Down syndrome, of course, can cause changes in the bone marrow and may cause leukemoid reaction. And sometimes even they can present with the leukemia also. So basically, the thrombocytopenia could be in a normal child. We should think whether there is any problem between the mother and the baby, just like incompatibility, which may cause autoimmune thrombocytopenia if the baby is completely normal. But this particular child was growth restricted and ecchymosis were there. So more suggests of an intrauterine infection, but for features of Down syndrome. I don't know why antibiotic was given, probably because there was nothing to suggest infection as such except thrombocytopenia with the high count. But once bone marrow was also not suggestive, I think the antibiotic might have been needed. So thrombocytopenia can also occur because of intrauterine infection, or autoimmune thrombocytopenia can occur, or primary thrombocytopenia can be because of some maternal drugs also it can happen. So there could be multiple causes for thrombocytopenia in a newborn. Dr. Binu, you want to add something more?
Well, basically we calculate, we classify them as thrombocytopenia in the presence of a well baby or an unwell baby. And the well baby, we think about the NAITs, that is your alloimmune thrombocytopenia. And if it's an unwell baby, then we think about your DIC, or as said, it's the bone marrow suppression because of or intrauterine infection. In the presence of a Down syndrome, of course, the whole story changes. But otherwise, the common classification is well baby with thrombocytopenia, unwell baby with thrombocytopenia, and that's how we proceed.
Okay. And is there a difference between congenital leukemia and the transient myeloid abnormality that she is describing?
See, once you do bone marrow, probably it becomes obvious. See, when you have high counts, then it may be leukemia or it may be leukemioid reaction. I think the bone marrow picture differentiate between the two.
The doctor, what was the treatment given for this child, doctor?
Sir, at present, supportive transfusion care will be given, sir. We are monitoring weekly CBCs for platelet counts and total counts, sir.
The oncologist's opinion is that the child will get better with only periodic follow-up, or is there a chance that this child will develop a genuine leukemia, because we know Down syndrome babies are at higher risk of leukemia? Is a benign outcome anticipated?
Sir, we have to follow up for a transformation into an acute leukemia at the age of 3 years, sir. So we are following with weekly CBCs, as well as in clinically we have to look for any liver enlargement or a liver hepatomegaly with altered liver enzymes or any effusions. In that case, it turns out to be a high risk case, and we have to go for chemotherapy. That's what oncologists.
Thank you. Thank you. Thank you for that very illuminating case presentation. It was very nicely presented. Thank you so much. Can we go on to the next case, please? Do we have any more presenters? Hello?
I think we might still have Dr. Gurulakshmi actually presented.
Hello, sir. I'm Dr. Deepa from Davamri Medical College.
Yeah. Please go ahead.
Please.
Stop try sharing, please.
Okay. Is my slide visible, sir?
Yes, ma'am. Please go ahead.
Good evening, sir. I'm Dr. Deepa from Davamri Medical College. I'm going to present a case about dilemma in the diagnosis of neonatal sepsis and what is needed in today's scenario. Baby of Akshya, second one of non-consanguineous parents of gestational 38 weeks, delivered by LSES at DDMC in our college, of birth weight 2.4 kg, admitted in NICU with complaints of difficulty in breathing. Antenatal history is only history of low-grade fever was plus 2 days before the delivery. Recent history, an alive late preterm of 38 weeks, delivered by LSES. Indication for LSES is previous LSES in labor. Weight is 2.4 kg, cried immediately after birth, had respiratory distress. For that, the child is shifted to NICU with CPAP. On examination, the child is alert, tachypneic, no external congenital anomaly, vitals, respiratory rate heart rate 152 per minute, respiratory rate 72 per minute, saturation is 94% in room air, CRT less than 3 seconds. Systemic examination, CVS S1, S2 plus, no murmur, RS bilateral air entry plus, no adult sounds, parabdomen soft, no organomegaly, CNS AF normal, tone normal, neonatal reflexes plus. Investigations, the child X-ray was taken with chest X-ray with abdomen with NG tube in situ, and that was normal. So prevention diagnosis is transient tachypnea of newborn. For that, the child is treated with O2 food, IV fluids, warmer care, and close monitoring. After 6 hours, the distress is not settled. The child is still in tachypneic. So sepsis screen was done, which shows negative. Total count of 9,600, ANC 2,200, IT ratio 0.15, micro ESR 8 millimeter per hour. CRP is negative. Blood culture was sent. After 12 hours, the child activity is slightly reduced. Respiratory rate 80 per minute, tachypneic. Repeat chest X-ray was taken, that also normal. Echo normal. ABC shows normal. So the same management continued. After 18 hours, the child lethargic, still tachypneic. Respiratory rate is 84 per minute. Mild retraction plus. There was a shock and mild altered NG aspect was there. USG cranium, no abnormality detected. So we done procalcitonin, which came strongly positive of 34 nanogram per ml. INR is 2.2, APTT is prolonged 64 seconds. In view of shock, it is corrected with NS bolus 10 ml per kg over 1 hour. Due to strongly positive procalcitonin, we started a ciprofloxacin and amikacin. Due to NG aspirate, injection vitamin K and FFP 10 ml per kg was given. After 24 hours, the child became lethargic, still tachypneic, respiratory 72 per minute, but retraction reduced gradually. Repeat INR is 1.2, APTT 58 seconds. Mild NG bleed was there. So, in view of persistent worsening, injection meropenem was started and the second dose FFB transfusion was given. On day 3, the child gradually improved, distress settled, gradually went to room air, NG bleed stopped, polarized feed started and tolerating feeds and DBO was taken. Repeat procalcitonin is 1.5. On day 6, culture report came, which was the Klebsiella sepsis positive with sensitive antibiotics to meropenem and amikacin. So 10 days antibiotics was given and the child was discharged. Take home messages. One, delay in diagnosis of neonatal sepsis leads to complications yearly and increase the neonatal mortality and morbidity. Procalcitonin is very good biomarker to diagnose all form of neonatal sepsis. After appropriate antibiotic therapy, falling procalcitonin level correlate well clinically when compared to CRP. Though the cost of procalcitonin kit is high, it is negligible compared to cost burden of over antibiotic usage, drug toxicity, essence use tray and usage of inotropes, blood products, and long-term morbidity of neonates and mental illness to the parents. Thank you.
Thank you, Ma. Dr. Vishnu Bhatt, sir, your
Yeah,
comments on neonatal sepsis.
first and foremost, it is 38 weeks, so you cannot call it a late preterm. Anything below 37 weeks only is preterm. So the nomenclature is wrong. That is a late preterm. And this baby initially was normal. The counts, everything was normal. So is it a hospital-acquired Klebsiella infection? That's what I am thinking, because initially everything was normal. So don't go with the concept that procalcitonin should be done and it is very reliable. Definitely it is better but the cost is prohibitive or it's quite high. And you're not compared with the CRP and other things along with the procalcitonin to say that procalcitonin is definitely better and we will reduce cost, hospital stay and everything. And once the respiratory distress is there, ciprofloxacin is not the drug of choice. I don't know why you are given ciprofloxacin. And as such, ciprofloxacin and amikacin is not the usual combination which you use unless you have culture positivity sensitive to only those drugs. Because ciprofloxacin will try to avoid as much as possible. And if once a respiratory problem is there, definitely it is not a good drug. Later it changed to meropenem. So my serious suspicion is that this probably is a hospital-acquired infection. The child had probably a transient tachypnea of newborn, later developed more serious problem. Of course, infection should always be considered because a child otherwise normal can have infection. But you are not told whether PROM was there, mother had fever, which might have predisposed the baby to infection at birth. So after listening, I feel the baby had mild TTN in a term baby and probably developed infection from the hospital with the Klebsiella and became worse.
Dr. Binu?
Yeah, I thought the history presentation was that the mother had fever 2 hours before delivery and the baby came with tachypnea. That is what I understood from. Can you put the PowerPoint again, please? And show me that initial slide.
Maybe I would have heard wrong here.
Yeah, just put the slide again.
Not a hospital delivery?
Hospital delivery, but
It's a hospital delivery.
There was a maternal fever 2 hours before delivery, and then baby came with tachypnea is what I thought I saw, but if you put the PowerPoint, you'll probably see there. As a general rule, any baby presenting with a symptom or rather a sign which can be attributable to sepsis should be considered a sepsis unless ruled otherwise. That is the only way you save babies. So we may have a diagnosis of TTN, we may have a diagnosis of respiratory distress syndrome, but if there is a possibility that the symptom or sign can be because of infection, we would treat with antibiotics anyway. That is one point I wanted to make. The second thing was, you have the PowerPoint. Yeah. The second thing was that when you said the blood gas was normal, show that slide. Yeah.
No history of housemating, no history of leaking.
Yeah, history of low-grade
fever.
2 days before delivery. There's a story there.
Next slide, ma'am.
There's a last line. She has written a low-grade fever is written. And the next slide, please. And when did the child present with had respiratory distress? So the child was shifted with CPAP. So if the distress starting from the beginning, the next slide, please. And I don't see a blood gas being done for babies with respiratory distress the second time it's happening. In my opinion, as much as you take a chest X-ray, a blood gas is equally important. The next slide, please. Yeah. So I don't see, again, a reason why we shifted back to oxygen hood, because a child with a respiratory distress needing oxygen is much better off with CPAP than with oxygen hood. Oxygen hood does not really help in any pathological condition in a baby because the lungs are stiff, it needs pressure. The next slide, please. The next slide, please. Yeah. Now here you say a pH of 7.35 is normal, but a PCO2 of 22 is not normal. It clearly shows that the base excess of -6 is not normal. I don't know if your blood gas does not give lactate, but lactate would have been a very useful addition in that blood gas because it shows a baby who is probably hyperventilating there. And that could have been a feature of sepsis.
Dr. Binu, in the absence of ready access to procalcitonin for most practicing pediatricians, are there any simple sepsis scores which can rely on CBC and CRP and urine, which is far more readily available?
Yeah,
I mean, this is an institutional case that she's presenting.
Yeah, I agree. I don't use procancellin at all. I work in big institutions. I don't use it because to me, sepsis is a clinical diagnosis. And a newborn baby, born to a mother who had this fever off and on with a respiratory distress starting from birth, I would say that you would treat with antibiotics anyway. Procancellin is not going to change my management. Clinical sepsis is a clinical diagnosis. CRP is not going to change my management. I would start, and 2 negative CRPs 12 hours or 24 hours apart is a good negative predictive value for no bacterial sepsis. But otherwise, it's a clinical diagnosis, clinical management, which I think should be the life-saving thing for babies. Procancellin is something that, yes, it may help, but you should not take away as a take-home message that procancellin is going to save babies. It's not. It's a clinical diagnosis, clinical management.
Thank you. Thanks for that insight.
Sir, good evening, sir. Dr. Balaji from Dharmaburi, sir. Sorry for the disturbance, sir. Thanks for the valuable input, sir. Actually, as sir suggested, it is obviously sepsis a clinical diagnosis, but still in office practice, everybody looking for the septic strain markers to diagnose neonatal sepsis, sir. But the problem is that IT ratio or immature neutrophil counts and whatever things are practically not possible in all towns for office practitioners. Sometimes CRP will mislead us when CRP is negative. So many people are thinking that it's not sepsis and they start the treatment late. So in that situation, though procalcitonin kit is little bit high, it saves so many babies. And in diagnosing neonatal sepsis, to just highlight in the procalcitonin value only we presented this case here, sir, because it can be done at any lab. Though cost is little bit high, we should not miss the sepsis, and also we should not wrongly diagnose sepsis in newborns. That's why we presented the case here, sir. Thank you, sir. Thank you very much, sir.
Point taken, Dr. Balaji.
Yes, procalcitonin is definitely superior to CRP, but it is also not that much reliable as you say. If you see the published data, it is not confirmatory. Blood culture is confirmatory, and everything you have to take. Of course, patient sometimes may feel happy, yes, then the investigation with more cost. Otherwise, I don't know whether it really helps.
Thank you, sir. Do we have one more patient? One more case scenario to be presented?
Yes, sir. Salunagi?
I think that's the last one, isn't it?
No, there were
Salunagi?
2 patients, case scenarios from Dharmapuri. Term baby
Yes,
with
sir.
No,
respiratory.
but this is the last one, or do we have more?
Yes, sir. I'm here, sir.
Yeah, please go ahead. I think you just need to turn your mobile to.
If there are too many, you could have had 2 sessions.
Hello, sir.
Yeah, can you just turn your mobile by 90 degrees? It's the portrait mode. Can you just change it to the landscape?
Good evening, everyone. I'm Dr. Selunagi, pediatric postgraduate from Dharmaburi Medical College. I would like to thank my HOD sir and our chief sir, Baj sir and Narmada ma'am for giving this greatest opportunity. Here I'm presenting a rare cause that causes neonatal jaundice, we commonly encounter. Baby of Lakshmi, second born of non-consanguineous marriage, 38 weeks term, delivered by a normal vaginal delivery with a birth weight of 2.6 kg. Baby was admitted with complaints of yellowish discoloration of skin and eyes.
Salunagi, your slides are not visible. Are you sharing?
Yes, sir.
We can see it, ma'am. If you're not able to share it, you can present it like a story, ma.
Okay.
Yeah, we're running out of time. So if you have problems, okay, fine.
The Sahan Dravida mother, booked on the immunized.
Can you start from the beginning, please? Sorry.
Yes, sir. Okay.
Yeah.
Baby of Lakshmi, second born of non-consanguineous marriage, 38 weeks term, delivered by normal vaginal delivery with a birth weight of 2.6 kg. The baby was admitted with complaints of discoloration of skin and eyes on the 4th day of life. There was no history of pallor, lethargy, poor feeding, no history of inconsolable cry or seizure, no history of high-colored urine, pale stools, fever, rash, or hypothermia. Regarding antenatal history, Second gravida mother, Mr. immunized. Mother's blood group was B positive. There were no history of fever with rashes, cervical lymphadenopathy, PH, GDM, or hypothyroidism. Regarding natal history, the third 38 weeks pregnancy delivered by an uneventful normal vaginal delivery. There were no history of CAPSULES, staphylohematoma, subgaleal bleed. Baby was cried immediately after birth with an upscore of 7/10 and 8/10. Passed meconium and urine normally. Breastfeeding started within an hour of life. There was no feeding difficulty. No family history of jaundice. There were no family history of hematological disorders requiring blood transfusion, splenectomy. No history of neonatal in the family. On examination, the baby was alert, active. Sensorium was normal. Icteric up to the legs and arms. No pallor, no sign, no dehydration. Vital temperature normal, 36.5 degrees Celsius. Heart rate 148 per minute. Respiratory rate 42 per minute. Peripheral pulse felt well. CRP SM 3 seconds. Cardiovascular system S1 S2 present. No murmur. Respiratory system bilateral laryngeal present. No added sound. Per abdomen soft. Bowel sounds present. No clinical evidence of organomegaly or free fluid in the abdomen. CNS tone was normal. AF 2 plus 4 cm. Lax neonatal receptors are normal. At the time of admission, investigations were done. Complete blood count was normal. Total serum bilirubin 18 mg per deciliter. Direct 0.3 mg. Indirect 17.7 mg. Baby's blood group was B positive and DCP negative. Baby was treated with phototherapy for 2 days. And the SBR was repeated 10 mg per deciliter and the baby was discharged. Mother came for review on 9th day with complaints of liver discoloration. Baby was eccentric up to the legs and arms. Then repeat investigations were taken. CBC was normal. Serum bilirubin 18.7 mg per deciliter. PSH was normal. DCT negative. Mother ICT negative. G6PD with normal limit. Peripheral smear, no evidence of hemolysis. Reticulocyte count was normal. Baby was treated with phototherapy for 2 days. And the repeat SPR was taken. It was 10.1 mg per deciliter, direct 0.5 mg per deciliter, indirect 9.6 mg. Then the baby was discharged. Mother came for review for after 3 days. Baby found eccentric. CBC was normal. Serum bilirubin 17.1 mg per deciliter. SGOT, SGPT were normal. USG abdomen pelvis were normal. After ruling out all possibilities of jaundice, breastfeeding jaundice was considered. The mother advised to stop breastfeeding for 2 days, advised to formula feed for 2 days. After 2 days, SBR was 8.2 mg per deciliter. After 3 days, SBR was 5 mg per deciliter. So when there is no fixating factors or features of hemolysis, in case of prolonged physiological jaundice, breastfeeding jaundice should be considered. Beta-glucanase, a factor that present in human males, they deconjugate intestinal bilirubin and promotes its absorption. So it increases serum bilirubin level. The breastfeeding is not, bilirubin level will fall rapidly in 48 hours.
Thank you, Ma.
Thank you.
Professor, we'll have some comments and close the sessions.
It's not very common. Most of the breast milk jaundice will go like physiological jaundice. Very unusual for a child who was bilirubin came down again to increase. But we should also consider if the jaundice persists, other non-hemolytic hyperbilirubinemias, which are not very common, but could be the causes if it repeatedly rises, because they will also respond to phototherapy. Any indirect hyperbilirubinemia will respond to phototherapy. So in this case, probably it was breast milk jaundice because after I stopped feeding, it came down, did not rise further. It is not known why restarting breastfeeding does not increase, but once it comes down, people say it does not go up. Only thing, a good point was that this child was looking healthy, sepsis screen was negative, everything was positive. So,
thank you, sir. Dr. Binu, do you want to add any comments to that?
Dr. Gurulakshmi, you wanted to say something?
Sir, I have to present the case, sir.
Sorry?
Dr.
Hello.
Gurulakshmi is here. I think there's one more case presentation. I think she's ready
No,
for it.
I just want to, yeah, I was just asking for your comment on this check.
Sure. Okay, so the one of the concerns always has been that is this breast milk jaundice purely because of these deconjugating factors? And if you do, nowadays there are articles that come out that if you do genetic testing on all these so-called physiological jaundice, exaggerated physiological jaundice, breast milk jaundice, you do find some mutations of the UDP glucuronidase transferase enzymes. And that is probably what precipitates it from one end to the other. But otherwise, as I said, persistent jaundice, if you investigate, breast milk jaundice is not uncommon. We often find this happening, but repeatedly going back onto phototherapy is rather uncommon.
Mm-hmm. Thank you. Dr. Gurulakshmi? Dr. Gurulakshmi?
It is 10 o'clock. He's gone for
I
dinner.
apologize
Yes,
for
sir.
the delay, sir. I think
Yes,
we
sir.
do not budget for
Hello.
much of enthusiasm
Yes,
and
sir.
discussion.
Doctor, yeah, please.
Hello.
Yeah. Gurulakshmi, you can proceed now. Hello?
Hello.
Hello, can you hear me?
Yes, sir.
Yeah, please
I'm
proceed.
audible, sir.
Yeah.
Dr. Lakshmi, you can start presenting, ma.
Sir, I'm audible, sir.
Yeah.
Yes, ma. Please. Yes.
Yes. Sir. Good evening, one and all. I'm going to present a case of term baby with respiratory distress. The term baby presented with respiratory distress on hour of life 14. Term baby who was first born 8-year-old primi gravida, married since 1 year, no antenatal risk factor was found in mother, major congenital anomalies was found. Growth scan, the liquor was normal, fetal growth was normal. Natal period, no history of maternal fever, PROM, foul smelling liquor, chorioamnionitis, Baby delivered by emergency LSES due to non-reassuring CTG. Baby cried at birth. The liquor was meconium stained. Birth weight of the baby is 3 kg. Apgar score at 1 minute and 5 minutes is 7/10, 8/10 respectively. Baby had respiratory distress at birth with Downey score of 2/10. In vitals 68 per minute.
Your voice is breaking.
The unstable internet connection.
Nasal O2 at 1 liter per minute. The distress was settled within an hour. Hello, sir. Hello.
Proceed, ma. Proceed.
Please go ahead, ma.
On hour of life 14, baby had respiratory distress, which was progressively increasing in nature, and no history of regurgitation of feeds and no history of aspiration, vomiting. At the time, the heart rate was 164 per minute and respiratory rate 78 per minute, and SpO2 82% at room air in all 4 limbs. No pre and post-ductal oxygen saturation differences was noted. And cardiovascular system, the heart sound was equally heard on both sides, and respiratory system, right side air entry was normal, left side there was decrease in the air entry, and work of breathing was increased with subcostal retraction. Per abdomen soft and not scaphoid. CNS anterior fontanelle flat and tone and reflexes was normal. Baby started on nasal O2 via prongs at 1 liter per minute. Even with oxygen via prongs, the saturation does not improve and distress continue to worsen. With this clinical history, we thought it may be a meconium aspiration syndrome with PPHN or early onset sepsis, pneumonia, or pneumothorax, a critical cyanotic congenital heart disease. The investigation, we proceeded with chest X-ray, CBC, CRP, blood culture and sensitivity, and echocardiogram. The echo shows a no major complex congenital heart disease, PDA with a PFO. The CBC and CRP was normal. The chest X-ray shows a feature of congenital diaphragmatic hernia in the left side. Once the diagnosis of the congenital diaphragmatic hernia was made, we initiated with a supportive management. Temperature was maintained under the radiant warmer servo mode. Baby was intubated and connected to the mechanical ventilator, and baby kept under NPO, continuous NG drainage, to decompress the bowels and stomach, and IV fluids, IV antibiotic were initiated. Baby condition was informed and referred to the higher center for surgical management. At Haracliff 48, the congenital diaphragmatic hernia repair was done, and the child is stable now. Thank you, sir.
Thank you. Dr. Vishnu Bhatt.
At what age this X-ray was taken?
Haracliff 14, sir.
14 hours.
Yes, sir.
So you did not suspect diaphragmatic hernia because the diaphragmatic hernia appears to be quite significant. Probably the diagnosis was missed. Right? Hello?
Yes, sir.
So how do you diagnose the diaphragmatic hernia at birth? Not all diaphragmatic hernia will diagnose at birth, but certain things which make you suspect diaphragmatic hernia.
Scaphoid abdomen and displaced heart.
Did you go for resuscitation of this baby?
Yes, sir.
So did you notice scaphoid abdomen?
No, sir. No scaphoid abdomen, and air entry was equal on both the sides at the time of birth, sir.
But you see the left side full of bowel loops. So obviously it must have had scaphoid abdomen, you might have missed. But one problem with the meconium stained liquor is that when the meconium comes out, abdomen may look a little empty. Sometimes you may miss the scaphoid abdomen. You may think it is because the meconium passed. But when there is a respiratory distress, you have looked for heart sound murmurs. But you would have noticed the cardiac impulse is shifted if you had carefully examined this baby, because so much shift of heart is there. So I think probably you should have taken more care in examining this baby. Of course, the treatment you had given immediately, that surgery was done, but it could have been diagnosed early. That's what I feel.
Okay.
Dr. Binu?
Yeah, as I said earlier, the examination of a newborn baby with respiratory distress is incomplete without an X-ray. So 14 hours, no X-ray to me is not an acceptable medical practice. If a baby is admitted in the NICU and there is tachypnea, you're going to start oxygen, what are you starting it for? What is your working diagnosis? You cannot have a clinical diagnosis without X-ray, not in the current age. Those days when the X-rays were not available is different, but now you should be able to have an X-ray to look at the X-ray and take a decision. So as a rule, an X-ray and a blood gas is part of the armamentarium of a clinical examination of a neonatologist in an ICU. And the second thing is many of these diaphragmatic hernias are nowadays picked up antenatally. And it is very unusual that the X-ray nowadays we are caught by total surprise in a diaphragmatic hernia. Often the babies who present with such mild condition, because in 14 hours baby was coping well, is that there's probably a small eventration rather than a full-fledged diaphragmatic hernia also. That is one more of the differential diagnosis.
Okay. So many often these patients come to us for antenatal diagnosis as to whether they should continue with the pregnancy or not. Are there any useful pointers, Dr. Binu, we can confidently reassure them that the underlying lung would not be hypoplastic and this child could have a successful repair and a good quality of life?
Yeah. So usually we have that heart-lung ratio, and that can give you a definite, give an indication of how the lung is developed in proportion, and therefore we can say whether the child is going to be good or not. But as a rule of thumb, what I have found is that the way the baby responds after birth is the only thing that really gives an answer. What is the oxygenation index when the baby is after the baby is born is what is going to get an outcome. So when any parent with a diaphragmatic hernia comes to me for antenatal consultation, our outcome for diaphragmatic hernias is more than 80-85%. So I usually give them a good prognosis, and I tell them that we can give an outcome only after the baby is born. Yes, your scans do show that the lung-heart ratio is such and such. It looks good, but eventually on that day when the baby is born, whether the lung is going to be able to cope or not, we will know only after baby is born. So I do not recommend any baby or any mother to go for fetal abortion for that reason.
Perfect. Thank you. Thanks, sir. Thank you so much.
Ashwath, only one question from my side. Ashwath, hello.
Please ask. Please ask now.
Dr. Binu, your experience with the chlamydia pneumonia and its presentation, please.
I have not yet diagnosed a case of chlamydial pneumonia. It is always a differential diagnosis of a child with a late onset pneumonia, for which we start with erythromycin. But otherwise, I have not yet have a diagnosis made of a chlamydial pneumonia. Probably Dr. Vishnu Bhatt would probably be able to give you a better answer to that.
Of course, I think what you put it rightly only. But nowadays, you can make all diagnosis because PCR machines are there everywhere. So you may be able to make a diagnosis. Basically, it does not make much difference whether it's due to chlamydia or viral, except the treatment. So if you have a definite diagnosis, then it becomes easier for you to manage the case. So normally, I think it is of a intuition rather than anything else. Then you can investigate.
Yeah, because since we were discussing about neonatal pertussis, I was curious about this chlamydia also, sir. So only ask this question. Thank you, sir. Thank you very much for the explanation.
That case also, they have done PCR. So with PCR, many of these diagnoses can be made probably. Because culture probably is not much useful.
Yeah.
Dr. Ashwath? Yeah, Dr. Ashwath?
Yeah, please, sir.
Yeah, a very important point has been made by both neonatologists. You see, the basic principle of the management hasn't changed in the past 60 years. If you have a newborn with respiratory distress, a good history, a good physical exam, followed by an immediate chest X-ray is mandatory. A chest X-ray will rule out most of the treatable conditions, surgical conditions in particular.
Correct, sir.
I don't think one should postpone or wait. I think the dictum from 1960 onward has been a good history, good physical exam, and an immediate chest X-ray. Indeed, if my memory serves me right, the early neonatology books, the neonatologists in North America would say no newborn with respiratory distress would die without the benefit of chest X-ray. How good a clinician you are, lots of surgically remediable conditions could be completely missed if you don't take a chest X-ray immediately, and then you feel very reassured. Once the surgical conditions are ruled out, then you can think of it. It's a very valuable point that has been made by both the neonatologists, and I think, and the physical examination is still extremely important, very important. Subtle points like a diminished air entry on one side of the chest, the placenta noticed. It was not there at birth, but it manifested itself a few hours later. So position of the apical impulse, like Dr. Vishnu, but I think they're very important. These points, really help you to arrive at that. There is no need for a very lengthy differential diagnosis. Only confuse yourself. If you get just one or two conditions, and you can narrow it down. Thank you.
Thank you, sir.
Yeah.
Thank you very much.
So, boss, mudichilangla.
Mama, please.
Okay.
I think you delayed them too much now.
10:15.
10 o'clock.
Because of IAPTNSC, I thank today's moderator, Professor Dr. Vishnu Bhatt and Dr. Binu Nainan. And there was discussed extensively, excellent discussion also. I thank M. Ramsamy sir who has helped us to make this enable to us. And I thank all the presenters from various institutions throughout Tamil Nadu. And on behalf of IAPTNSC, I thank all the delegates also. I thank our President, Dr. Suresh Palan, our Secretary, Dr. Thirumurugan, and Dr. Dashani Treasurer. Dr. Thirumurugan,
Thank you, sir. Thank you. Thank you very much, actually. So it is enjoyable with because we have had really different cases. Some of them pretty simple and obvious. Some of them definitely there is always some surprise behind the obvious presentation or obvious investigation. My special thanks to both Professor Vishnu Bhatt sir and Dr. Vibhinan for excellent discussion and very valuable inputs. Again, my thanks to our academic coordinator, Dr. Rajendran and Dr. Ashwath for again conducting a very useful session. And my special thanks to all the presenters for the day. Thank you very much. Good night.